everybody, my name is Jessica and this is my proficiency-based head-to-toe assessment. I'm going to start my examination by washing my hands. That can either be done with hand sanitizer or by washing with soap and water. Upon entering the room, I'm going to introduce myself to the patient. Hi, my name is Jessica and I'm going to be the NP seeing you today. I'm just going to start by asking you a couple orientation questions. I know they're silly, but if you could just humor me and tell me both your first and last name.
David Wilson.
Hi, Mr. Wilson. Nice to meet you. And what brings you in today?
Just establishing care.
Okay. So a couple of routine questions we like to ask every time you come in. How's your mood?
Doing pretty good.
Okay. Are you having any decreases in appetite?
No.
Are you having any decreases or abnormal weight gain or loss?
No.
Okay. Are you having any thoughts or feelings of depression?
No.
Are you having any thoughts, feelings, or actually have harmed yourself?
No.
Are you having any thoughts or feelings of harming others?
No.
So all of that goes in to establish your patient's affect, and Mr. Wilson seems to be in a appropriate mood this morning. I'm also going to note that the patient is appropriately dressed for the late summer weather and that he has good hygiene and he seems to be well put together. So we'll just start here at your head. If you notice any tenderness, please do let me know as I'm touching and palpating. So palpating the scalp for any lumps, bumps, or abnormalities, noting that the hair is equally distributed across the scalp. The color is a nice blonde color. The texture is even throughout. Are you having any tenderness in your scalp at all? Okay, and then additionally noting that it is a nice pink color indicating it has good vasculature. Moving on to your face, we're going to have you do just a couple of movements that assess your cranial nerve function. So specifically looking at cranial nerve 5 and 7, I'm going to ask that you'll show me your teeth and smile, raise your eyebrows, and puff out your cheeks full of air. Good. All of those are normal findings that he can perform. We're then going to palpate the patient's face or touch the patient's face for sensation. So as I'm touching your face, Mr. Wilson, if you'll tell me if you don't feel that equally on both sides. Okay, we're then going to assess the TMJ or the temporomasseter joint that's here at the jaw and ask you to move your jaw through a couple ranges of motion. If you could open and close, move your jaw side to side, and jut your jaw forward. If you'll also clench your teeth. So when the patient is clenching their teeth, you're assessing that temporomasseter muscle there at the temples and the jaw. While he was moving his jaw, I was feeling for any abnormalities, locking or popping, and it was a nice, smooth, fluid motion. We're then going to check sternocleidomastoid resistance, which is done by placing your hands on your patient's shoulders, asking them to shrug their shoulders. Good. And then additionally, you can place the palm of your hand on the patient's face and ask them to turn into your hand, and again on the other side. And those are all noted to be normal. We're then going to assess the head and neck for all of the, majority of the lymph nodes. So we're going to start here in front of the tragus with the preauricular, moving behind the ear to the postauricular, moving to the occipital at the base of the skull, the superior cervical, palpating down the sternocleidomastoid muscle for the deep cervical chain, palpating the posterior cervical, palpating, lift your head just a bit, palpating the tonsillar at the right angle of that mandible, palpating the submental under the chin, and the very forward anterior portion of the chin, palpating the submental. We're going to ask the patient to look right and left, palpating the supraclavicular, and under the clavicle for the infraclavicular. Noting those lymph nodes. When you're palpating those, you want to note any swelling or tenderness that the patient might be feeling. Are you feeling any tenderness? Okay. We're then going to assess the patient's eye function. So that can be done just using a simple pen light. We're going to start by assessing the 6 cardinal positions of gaze. While the patient is following the object with just their eyes, you're going to note how the eyes move, and noting any unfluid movements. Sorry, we're almost done here. And the other direction. And then we're going to hold the object at the top and look for any nice stigmas, which is bouncing or jumping of the eyes. None of that was noted to be present. Take a couple blinks there in between. We're then going to test the visual, peripheral vision or visual confrontation. So I'm going to step and hand up and down, and if you'll nod when you can see my eye, good. We're then going to look at the third cranial nerve. When we were testing those 6 cardinal positions of gaze, we were looking at 3, 4, and 6. We're now going to further assess the pupils, making sure that they're equal, round, reactive to light, and that they also accommodate. I apologize, big bright light, looking here at my finger. So you're going to check both sides, making sure that those pupils constrict consensually, and his are noted to be at about 3 millimeters in size. And then we want to test that accommodation. So you'll hold the object in front of your patient and just ask them to follow it in with their gaze. Perfect. Take a couple blinks. Sorry, I know it was rough. We're then going to use the ophthalmoscope and look at the patient's red reflex. So just look forward. So when you do the red reflex test, you want to see that nice orange-red color looking back at you when you look through the ophthalmoscope. You don't want to note any obstruction or any cloudiness. Moving in towards the eyes, we're going to look at the conjunctiva. So we're looking for any drainage or discharge, and also the color of the sclera. And Mr. Wilson's are noted to be free of any drainage and a white normal color. You're then going to assess your patient's eyebrows, looking for any scaliness or thinning and the distribution of the hair, which is evenly distributed and normal. We're then going to look at the eyelashes. So you want to assess that the hair is evenly distributed on both sides, the contour of the lashes, noting any inversion and any styes along the eyelid line, which is absent in our patient, Mr. Wilson, which is normal. We're then going to move to the nose and the mouth. So again, using your light, you can inspect the internal structures of the nose after looking at the dorsum or the bridge of the nose and the tip of the nose, noting any symmetry or tenderness upon palpation. Any tenderness there? And it appears symmetrical. So you're going to assess the internal structures, the internal mucosa of the nose. And you want to see pink, moist mucosa that is free of any drainage or any lesions. You're then going to test nasal patency by having the patient occlude one nostril and sniff, and again on the other side. All of those are normal findings. Moving on to the mouth, we're going to inspect the teeth, gums, and the tongue. So we're going to first look at the teeth. If you could just show me your teeth and open. Okay, and open. Okay, so when looking at the teeth, you're looking to make sure that there is no decay and there are no dental caries. When looking at the gums, you want to know that they are pink and firm. Then when looking at the tongue, I'm going to have you stick your tongue straight out. You want to look at the papilla and notice the even distribution, which is normal finding. That's the dorsum of the tongue. Then you'll assess the ventrum of the tongue and have the patient lift their tongue and also assess the frenulum. When inspecting the oral buccal mucosa, you want it to be moist, pink, and intact. You want it to be free from any drying, lesions, or any bite marks, which was observed in our patient, Mr. Wilson. You're then going to observe your hard palate in the front and the soft palate. Both of them should be pink and moist. You want to assess your patient's uvula, noting if it's midline, and then you'll assess your patient's tonsils or the fossa if they've had their tonsils removed, noting that they are absent of redness or swelling. So we'll take one more peek. And Mr. Wilson's tonsils are in fact present and there is no swelling or redness noted. For this examination, we're just going to look at the external features of the ear. So palpating both of your pinnas and noting for any deformity or tenderness. You also want to note that the outer edge of the ear, the top portion of the pinna here, makes a parallel line with the outer canthus of the eye on both sides. And it does. Excuse me. We're then going to assess our patient's trachea, noting that it is midline without any deviation to the right or the left. We're going to assess for any sort of passive range of motion for lumps, bumps, or tenderness of the neck. When we're assessing these joints, we're looking for any heat, deformity, or crepitus. And we're going to ask our patient to put his neck through some active range of motion by having him dip his ear to each appropriate shoulder. Okay. We're then going to look at vascularity, so we're going to feel for his carotid pulses, noting the rate, rhythm, symmetry, and grade. And they are bilaterally equal at a 3. We're then going to move to the patient's upper extremities, testing the brachial pulses and his radial pulses, again noting rate, rhythm, symmetry, and grade. We're going to have the patient turn his hands over, and we're inspecting the shape and contour of the fingernails, noting for any clubbing, which is absent. As you're assessing your patient's skin, you want to note the temperature and that it's warm. It should be moist, free of any abrasions, and note any edema. Mr. Wilson does not have any edema and he has warm, moist skin. I do want to point out though, he does have a flat brown macule that is about 2 to 3 millimeters in size. It is symmetrical and does appear to be normal. We're then going to assess Mr. Wilson's anterior chest and his lungs. Before listening to his lungs, we do want to note that he does have an appropriate 2-to-1 diameter ratio of the anterior chest to the posterior chest. And we're going to observe his rate of breathing. He has nice, easy, controlled breathing. Are you feeling distressed at all? Okay. And then also that the rate is between 12 and 20, which is adequate for an adult. When auscultating the lungs, it's important that we listen over all lung fields, including under the arms. Normally you'd have your patient take nice, slow, big, easy, deep breaths throughout this entire portion of the exercise. However, to prevent Mr. Wilson from passing out, we're going to ask him to breathe normally. And we'll just observe the points of auscultation. Making sure we get up under both arms to assess the bases of the lungs. There are no noted adventitious breath sounds. They are clear throughout, so lacks rales, crackles, or rhonchi. We're then going to palpate the anterior chest, feeling for any masses or tenderness, and there are none to be noted. We're then going to use the outer edge of the hand or the palmar inside of the hand to attest to tactile firmitis. While doing this, we're going to feel for any vibratory feeling on the side of your hand while the patient repeats the words 99.
99, 99, 99.
Slow down your 99.
99, 99, 99, 99, 99.
Okay, and again, just making sure that you feel all of those lung fields. So absence of that vibration usually is indicative that there's no consolidation, such as a pneumonia. Moving to the back side, we're going to have the patient spin on the stool here. We're going to assess the patient's lung fields on the back as well. So again, auscultating with all of the lung fields. And taking big deep breaths. Taking note to listen to all of the bases of the lung fields, which sometimes lies behind where this bra strap would be in a female patient. Again, listening to under the arms for all breath sounds, noting if there are any adventitious breath sounds. We're going to again palpate any tenderness for any masses there. You would again repeat your tactile firmitis, asking your patient to repeat the words 99, feeling all throughout, making sure there's not any of that vibration felt on your hands. In addition to tactile firmitis, we're also going to percuss. That's typically done with the middle finger of each hand, and you percuss over all of the areas of the lung. Noting that when you percuss over bones, such as the scapula here, that you get a flat sound, and as you percuss over the lung fields, you get a resonant sound, as opposed to if you were palpating over the liver or a solid organ, you get a dull sound. While the patient is turned this way, you also want to assess your costrovertebral angles, which is where the kidneys are. So you just give one firm tap and note any tenderness. And none noted. So we'll have our patient turn back around here. And we're going to move on to the cardiovascular portion of the exam. So, of note, during this portion of the exam, you would listen with both the diaphragm, the large side, and the bell, the small side, of your stethoscope, to the 5 oscillatory points that we are going to go through. For the sake of this video, we are just going to use the diaphragm. So you would want to listen to the aortic valve, the pulmonic valve, Erb's point, the tricuspid valve, and the mitral valve. You also want to assess the point of maximum impulse, or the PMI, listening to the apical pulse, which is found on the left lateral side, mid-clavicular at the 5th intercostal space. You do this portion of the assessment for a full minute. That's a full 60 seconds, not 15 times 4. And there were no abnormal sounds noted while completing that. There were no murmurs or gallops. A nice steady S1, S2 was present. For the next portion of the exam, we're going to inspect and palpate on the abdomen. For the sake of this space, we're going to just visualize and not lie flat, but you would have your patient lie flat to do the best portion of the exam. So first you would observe the contour of the abdomen, noting if it were flat or obese, visualizing for any peristalsis movement that you could see. You're then looking at the vascularity of the stomach and noticing any striae that might be present on the abdomen. We're then going to auscultate in the 4 oscillatory points, listening for a minute at each one of them: the right lower quadrant, the right upper quadrant, the left lower quadrant, and the left upper quadrant and the left lower quadrant. You would then palpate the entire abdomen, starting with light palpation, noting any tenderness, and then do some deep palpation. When you're completing your deep palpation, there's several different methods that you can use. However, you can use such as the Murphy's method, when you would have your patient take a big deep breath in and exhale. If they indicate that there's pain when doing that deep palpation, that would be a positive sign. So you would assess both the liver, which is over here on the right, you would assess the spleen, and then while your patient's lying flat, you would assess both of those kidneys in the area of testing that costal vertebral angles earlier. Noting that those structures might be difficult to feel unless it is a very thin person, or if they are overly enlarged, then they will be easier to feel. For the next portion of the exam, we're going to have the patient do some passive and active range of motion. So of note, this patient actually has had left shoulder surgery, so there are some limitations with that joint. So we're going to start just by assessing the joints. Please let me know if I'm hurting you. And moving them through some passive range of motion, noting any crepitus or discomfort, heat, or swelling in the joints, doing the shoulders, the elbows, the wrist, and the hands. We're then going to ask the patient to perform some active range of motion. So we're going to ask you to put your hands behind your back, behind your head, behind the small of your back. We'll ask you to stick them straight in front of you and raise them up. For your elbows, we'll ask you to put them out, in, and do inversion and eversion. Okay? With your wrist, we'll ask that you up, down, inversion, eversion. Okay, with your hands, we'll ask that you all 5 fingers spread on both hands, and then clench fist. I'll ask you to give me a good grip squeeze, and then thumb opposition, just bringing the thumb and each finger together. And those are all noted to be completed and done with smooth motion. Okay, you can relax your hands. We're now going to move on to the lower extremities. So again, checking for vascularity. So sometimes this is easier done when your patient is lying flat, but you're going to assess your femoral pulses, your popliteals behind your knees, your dorsalis pedis on top of your foot, and your posterior tibialis. He is noted to have both 3+ strength pulses throughout, and again, you want to note that rate, rhythm, symmetry, and grade, and they are equal bilaterally. Taking note that he does have good vascular distribution, as evidenced by the amount of hair that is present and equally distributed on his legs. When assessing his legs for that vascularity, you're also looking at your skin, noting that it is also warm, race appropriate, and no edema is present. We're then going to look at passive range of motion, so we're going to look at all of those joints. So we're going to assess the spine, the hip, the knees, the ankles, and the feet. So let me know if you have any tenderness.
Nope.
And while we're doing that, we're feeling both the hips. We're feeling those joints again for any swelling, crepitus, any heat. And are you having any pain as I'm moving through those joints?
No.
Okay. We're then going to do some active range of motion. So we'll have the patient stand up. We're going to bend forward and touch your toes. And then we'll stand up. And then we'll do some hyperflexion. And then flex over to each side, assessing that spine. For the sake of this video, we're just going to do one side, but you would do both sides. So we're also going to test those hips. So we're going to have you adduct across the body. We're going to have you abduct out. We're going to ask that you can raise that knee, extend the knee, flex the knee, lift the knee. Then with that ankle, we're going to point towards the floor, which is plantar flexion. Bring those toes towards your nose, which is dorsal flexion. Turn your feet inward for inversion and outward for eversion. And again, you would have the patient perform the same on the opposite side. You can go ahead and take a seat. We're then going to look at some of the sensory function of the patient. So we're going to use an object that has both a sharp and a dull side and ask the patient to identify if he feels the sharp or dull side.
Sharp. Dull.
You want to look at the upper extremities. You want to look at the trunk.
Dull. Sharp.
And you want to look at the lower extremities.
Sharp. Sharp.
And he was able to correctly identify all of those. We're then going to look at stereognosis. So this is typically done with a common object and asking the patient to close their eyes. You then place the object in the palm of their hand and ask them to identify the object.
Key.
And a key is commonly used for this practice. We're then going to look at graphesthesia, which is asking the patient to close their eyes again and place their palm up. And then we're going to draw a common letter or structure and ask the patient to identify it.
X.
One more time.
X.
Okay, and he correctly identified the letter X. The other thing that we will do, we'll demonstrate it here because the patient has shoes that are easily removable, is proprioception, which is where you can ask the patient to close their eyes. You use their great toe and you point it upwards or downwards and ask them to indicate which direction you are pushing or pulling their toe. And he had correctly identified up, and you would do that on both sides. After testing those sensory functions, we're going to test some tendon reflexes. Again, you would test on both sides for symmetry, but we're just going to test on one side. So we're going to start and we're going to do the biceps tendon. And note the bicep for that reaction. We're going to lift the arm and ask the patient to relax and test the tricep tendon. Going to relax their arm into the lap and look at the brachioradialis or supinator. That's noticed by having that hand jump. It's a little bit subtle. We're going to look at the knee or patellar. We're going to look at the Achilles, and this is done by having the patient relax their foot into your hand and striking on that outer malleolus. When they elicit this response, you see a slight plantar flexion. We are also going to use a dull object to assess the plantar surface here. So you do this by drawing an S on the bottom of the patient's foot. When doing so, if they elicit a Babinski's or that fanning of the toes, you see that that is abnormal in an adult, and if those toes curl under, that's normal. The other reflex we're going to test is clonus. Sometimes this is easier done when the patient is lying flat. You flex the foot forward and then release the foot. If the foot slowly comes back to its natural position, that is a normal observation. If the foot bounces and jumps, that is positive clonus. This completes the head to toe portion of my exam.